In my view, my own personal, totally unbiased view, it's all to do with the nature of networks, networks in space, in time, with age, with frequency of sex, with kind of sex, with connectedness, with clustering, with social class. All of these things are what determine the epidemic. But of course, these are difficult problems, hard to address, and I think that may be why we still understand so little. But then before we start to make predictions, it's worth bearing in mind a remark made by Stephen Hawking, who said that, you can tell I was a physicist once, theory allows us to make predictions which can be tested. If the observations agree with the predictions, the theory survives to make further predictions, which again are tested. If the observations don't agree with the predictions, one abandons the theory. I would rather use the word refines rather than the word abandons. But the point is, what matters is what happens in the real world. The theory guides us. It tells us what to do. It says, this is a good idea, that's a bad idea. But at the end of the day, we never believe the results of the theory. We believe the results of the empirical work, which we do in the field, the kind of work which Julio and his team have done so effectively in Vancouver. Okay, so here now is a dynamical model. Again, we come back to South Africa. This is the prevalence of HIV in South African adults. We fit the usual SI sort of model. That enabled us to get an estimate of the prevalence, the incidence, the mortality. The steady state incidence is then, the steady state levels of the epidemic are determined by heterogeneity in sexual behavior, behind which is this whole big elephant of sexual networking, which we don't really understand, but we put it in some fairly crude fashion, and that allows us to adjust the level at which the epidemic saturates. We also know just in passing that the reason why the incidence declines is not because we've done anything. It declines because we're running out of susceptibles. This is the incidence per person in the population. If you plot the incidence per susceptible person, it levels off. It doesn't go down. So you have to be very careful when you start talking about 25% reduction in incidence in South Africa or anywhere else in the world. That's going to happen anyway if you're talking about total incidence. So the incidence reductions that people are talking about and very pleased about may simply be a reflection of the natural dynamics of the epidemic and may actually tell us nothing about our control or our interventions. But you've got to be even more careful now. This is data from Zimbabwe, and for reasons which none of us understand, I don't think anybody can put his hand on his heart and say he understands this. This is what's happening in Zimbabwe. The blue line is the prevalence data, black dots are mortality data, red is incidence data. The incidence data, of course, are very thin. The mortality data is somewhat better, as is the prevalence data, but for reasons which we really don't understand, HIV in Zimbabwe is disappearing like snow in the desert, and none of us really know why. We say, well, you know, behavior change, and indeed I think there had to be some kind of change, and the change had to be some kind of change relating to sexual practice, so it had to be some kind of behavior change. But why did it happen in Zimbabwe, not in Botswana, Zambia, Malawi, Lesotho, Swaziland, or South Africa? None of us know. It's certainly not due to good government, but we still have to figure out the reason for this decline in HIV in Zimbabwe. But you know, if you'd said to me on the basis of that data and I'd had the data up to 2000, what's going to happen in Zimbabwe? I would have said it's going to flat line, but it didn't. So this is just a caution about everything we do in relation to modeling. At the end of the day, what matters is the data. But then we can use this kind of very simple model to look at the impact of high coverage tenofovir gel on HIV in South Africa, and this is work that I did with Slim and Qureshi Abdul Karim. So the blue line is our best estimate of what would happen if we rolled out tenofovir gel with high levels of coverage in the whole of KwaZulu-Natal. The shaded area, the confidence limits, you see they're enormous. They come from almost zero to quite big. And again, this simply reminds us that we need much better data. We don't want to be living with these wide confidence limits. You know, we hope that the real answer is down here somewhere, but it could be right up at the top. And what it tells us, and this is where the dynamical modelings become useful, is that, of course, as you roll it out, incidence drops immediately because you have an immediate effect. As soon as women start using it, incidence drops. Prevalence drops more slowly because prevalence, if you like, is cumulative incidence. So the incidence drops very rapidly, the prevalence more slowly, and of course the mortality even more slowly because people, they have to get infected, then it has to build up, then they have to die. So if we want to monitor the effect of something like this, we really need to be looking at incidence, not prevalence or mortality. Because it's the instance where we're going to see the immediate and rapid impact of whatever it is that we're doing. And then we get into the whole debate about BED and rapid and these sort of analyses for recent infection. But at least in principle, we can argue that tenofovir gel is not going to eliminate HIV. We've got the 30% reduction, not the 90% we're looking for. But we could save, you know, 2 million lives and 1 million deaths over the next 20 years. which is really very important, especially if you happen to be one of those several millions of people. So it doesn't get us to where we want to be, but it is very important. And of course, if we were to look at the results from Bob Grant's study, you'd get sort of similar sort of results. What if we do apply the same kind of simple model to ART for prevention? And many of you will have seen this before. Again, exactly the same slide as you saw before, prevalence, incidence, mortality in South Africa fitted to the trend data that we have. We roll out treatment for prevention over the next 5 years, starting here in 2010. By 2015, it's rolled out. We cut the incidence to very close to zero. Of course, what happens to prevalence is quite different, because what happens to prevalence is that all of the people who were not on ART are now on ART, so the number of people not on ART rapidly goes to zero because we're putting them all onto ART. But of course, those people are still alive. So we now have a lot of people who are still alive, they're still HIV positive, but they're on ART. So even in the most optimistic, wildly optimistic scenario, the problem is still with us until 2050, by which time I and many of us in the room will be long since dead. So the most optimistic scenario says we're in it for the very long haul. And we have to keep that in mind when we think about how we're going to fund this. Of course, mortality does exactly the same thing. People dying not on ART goes fairly rapidly to zero, but of course those people who would have died are now alive. They're going to die, hopefully, of old age, of natural causes sometime later. So these deaths we don't count over here. But what it does overall is it reduces the AIDS-related mortality from that black area there to that black area there. So we really could have, we could save the lives of millions and millions of people, millions and millions of individuals like you and us who want to go on living. The current strategy from WHO is to start ART at 350. Well, let us say we have a policy of 350, but we actually achieved 200 at the moment. In South Africa, we have a policy of 200, and we actually started a median of 120. So let's imagine that we had a situation where pretty much everybody, universal access at 200. We're aiming for 350, but we get 200. So this is pretty much what the World Health Organization is currently recommending. Again, exactly the same set of slides, but now starting a little bit later. We reduce incidence by about a half. We don't eliminate because we're not starting early enough. We reduce prevalence by about a half. Again, we don't eliminate because we're not starting early enough. The impact on mortality is much greater because, of course, we're starting early enough to stop people dying, but not early enough to stop transmission. Now, the reduction in mortality is very significant and very important, and we will save an awful lot of lives by doing what the World Health Organization is currently recommending. But the problem will then be with us forever, whereas if we do test and treat immediately, there's the prospect of bringing this thing to an end. If we look at TB, then this is the this is the incidence of TB in South Africa. The green area is the incidence of TB in HIV-negative people based on this model. It goes up slightly, but not by much for reasons which we can go into. This is the incidence of TB on HIV-positive people not on antiretroviral therapy. And this is the incidence of HIV-positive people on antiretroviral therapy. And the point is that ART doesn't completely stop, it doesn't reduce your risk of getting TB to what it was when you're HIV negative. It reduces by only 60%. So this is the 60% reduction, which we get very quickly. The rest of it comes because if we do test and treat, we finally eliminate HIV, and then, of course, we eliminate HIV-associated TB. Okay, what does it all cost? Well, I like this cartoon because what it reminds us is that you get what you pay for, and you have to decide how much you're going to pay. And I hope you're not entirely in the wild guesses scenario. Okay, let's look at, again, go back and look at tenofovir gel. Well, the cost per application of tenofovir gel in Slimmerdwood-Kim study was about 60 cents per woman per application. Interestingly, the tenofovir cost about 1 cent. The other 59 cents for the applicator and all the rest of it. So there's really good prospects for reducing the cost of that. The drug cost is almost irrelevant. It's the cost of all the applicator and stuff that you have to worry about. The woman in his study had on average about 60 sexual contacts per year, and the coverage in the high coverage group is about 90%. So that tells us the annual cost per application, number of contacts, coverage, and that tells us how much it's going to cost us per year if women using the gel. The incidence in this cohort was about 9% a year, so extremely high incidence. and the reduction in transmission